Welcome, everyone.
Welcome.
Thank you for coming to Mental Health 101. Natanya, do you want to start by introducing yourself?
Sure. Hi, everybody. Thanks for coming. My name's Natanya Mandel. My background is working with the charity and non-profit sectors in Australia. I worked primarily in mental health and crisis work, in domestic and family violence, in homelessness, in youth work, in sexual assault, and a number of other subsectors of the non-profit sector. I suppose relevant to this workshop, I set up a service in New South Wales, which is the most populated state, providing information, education, support and advocacy for carers and families of people living with severe mental illness across the state. So that's a really brief summary of me. I did the CTI core curriculum a little while ago. I can't remember when I finished. And am now setting up my coaching practice, and I'm about to undertake narrative coaching. So I'm very excited about that as well. So continuing my learning and growing. So that's briefly me. And I do have a fair bit of mental illness in my family as well, which is why I'm pretty passionate about this topic. So, Michelle.
Awesome, thank you. I can introduce myself first. So I am Michelle Anhang, and in addition to being one of the CTI Toronto community reps, I am a CPCC. I have my bachelor's in psychology. Oh, somebody's got some background noise. If you guys can mute yourselves. Thank you. I've got my bachelor's in psych. I've done mental health first aid training, as well as mindfulness and meditation training. I work with family members of people with mental illness and addiction to help them find balance and build resilience. I also have lived experience in this area. My husband died 13 years ago of suicide after suffering from severe mental illness. I have a son with ADHD and depression, and I also live with depression. So this is very close to my heart personally and professionally, and I'm happy to share all of my learning with you as well. So this workshop, in essence, is Mental Health 101. I know there's a lot of opinions and different things on what to do, and we just felt it was important to share with coaches the basics around mental health, mental illness flags, as well as covering what the ICF guidelines are around this. So, it's not covered in our training, and so there are gaps. So we want to just empower everyone with the basics so that you have better tools to cope if this arises in your coaching sessions with clients. Let's just move to the next slide. Sorry, guys, this is my very first webinar, which is super cool, but also I don't know how to navigate everything, so bear with me. So here are the objectives. We're going to identify the signs and symptoms of the most common types of mental illness and trauma, what to do if a client presents with suicidal ideation. We're going to cover the ICF guidelines, when and how to refer clients to a psychotherapist, and then discuss how the ICF differentiates between psychotherapy and coaching, and bring up as well when the coach has doubts. There's a lot of times where things will come up and we're not quite sure what to do, so we're just going to cover that briefly. And learn a few grounding techniques that if things do come up, a client gets triggered, it could be triggered by trauma, or it could just be a very deeply emotional session. Sometimes it just doesn't feel right to leave the client where they're at. And so it's helpful to know a couple of easy grounding techniques for yourself and the client to help with the transition with the end of the call. And at the end, we will have a Q&A. We're going to, because we have a lot of information to cover, we're going to ask that if you have questions, put them in the chat. The call is being recorded. We will try and answer what we can at the time, but I'm making the assumption that there will be a lot of questions. And we're also open to doing further webinars if there's a need or if there's a request. So by all means, post in the group if there are specific things that you're interested in learning about that were not covered here. We're also going to be sharing, if everyone could please mute, that would be awesome, because there's some background noise. We're also going to be sharing all the resources and the slides that are going to show up here, so don't worry so much about covering what's on the slides, like taking notes on that, because you will get all of that immediately after the call. So that's it. Take it away, Natanya.
Thanks, Michelle. All right, yeah, so please post, I'm not sure because there was background noise, but I think Michelle said please post any questions in the chat, and we'll collate those and try and answer where we can. So initially, really what we're trying to do is just give a brief overview of some key mental illnesses to assist you to identify where there might be an issue outside of the coaching arena. Most importantly, it's not our responsibility as coaches to diagnose. The information that we're providing you here is really just to help you notice if there's a need for a qualified mental health, mental health or health professional to provide some additional assistance. Just some key information to back you up. The World Health Organization estimates that 1 in 4 people at any one time estimates that that people will have a mental illness at any one time. Depression is the leading cause of disability worldwide, and 40% of people with mental illness do not receive assistance when they need it, and it's believed to be even lower for children and young people. So mental illness is really underserviced in our community. Michelle, if you could go to anxiety. Thanks. Sure. An anxiety-related disorder is different from normal anxiety that people feel, where it's more severe or intense, it lasts longer, and it interferes with a person's ability to function on a day-to-day basis. It affects their emotional state. Even when someone is not in a state of threat or danger, people feel anxious when they have an anxiety disorder. More than 70% of people with an anxiety-related disorder have one or another type of mental illness. And if someone has an anxiety disorder for a really long period of time, they're really likely to also develop depression. With depression, Michelle, if you could move to depression. And you'll get these slides, remember, so you can really look at the symptoms in the hive. Depression is a common and serious mood disorder. People with depression experience persistent feelings of sadness and hopelessness. They lose their sense of joy in day-to-day living. They feel helpless and worthless, and they may feel physical illnesses such as chronic pain and digestive issues. This disorder is different from sadness, which is often situational and may pass after a day or two. It can, people with depression can have a permanent state of helplessness and self-worthlessness, and it can have like a self-diminishing negative thought pattern. Michelle, do you want to go to the next slide? A person with some of these symptoms that you see written on this slide, they may have some or, quite a number of some of these symptoms. And some of these are similar to anxiety, but remember, it's not our job to diagnose. These are just flags to look at, so that you can think, maybe there's something more going on here. And this is simply to give you an indication, an understanding to think, well, maybe this person might need a referral to a health professional, back to their doctor, to a therapist, to get an additional amount of support, because it's something that they need more support on. With bipolar disorder, so again, remember, I'm going through really fast on these, and feel free to ask questions and I'll try and come back to them later. With bipolar disorder, this once was known as manic depression. It's a really serious mood disorder that causes people to swing between extreme, severe mood states. And the hive shows you some of the symptoms that people may display. People swim between extreme, severe moods. An up state is called mania, and a down state is called depression. The mood states deeply affect their energy levels, their attitudes and behaviour, and someone's ability to function in day-to-day world. It can damage relationships, impair their ability to function at work or at school, and even it can result in suicide. Mania is characterized by euphoric mood, joyful and energetic. They can be hyperactive, have an extremely joyful and expansive view on life, a hyper inflated sense of self-esteem, a grandiosity, and they can tend to demonstrate a decreased need of sleep. Sometimes someone in a state of mania can have rapid speech, where it's like their speech can't keep up with their thoughts, and they can be highly distractible. People in a manic state.
Natanya, we have a question.
Yep.
Oh, okay. Sorry, Gary was asking, how can you recognize bipolar disorder from text and email conversations? So that's a great question.
That is a great question. Well, I'm not really sure.
Yeah, save it for the Q&A.
Save it for the Q&A, and I'll have a think about that. Actually, that's a great question. So I feel like I need to take that away and have a think about it. It's a great question. And I might text. I'm just going to write it down. And Michelle, don't let me forget it. Really importantly for people in a manic state, often they'll show poor judgment and impulsivity. They're likely to engage in risky or dangerous behaviours and activities. Conversely, when someone bipolar goes into their depressive state, they'll be extremely depressed, and a lot of those symptoms are very similar to traditional depression. There are some key differences with extreme lack of energy, extreme lethargy. Their mood tends to be dysphoric, where they're extremely distressed and negative and unhappy, but that can display in different ways. And they can be extremely irritable, short-tempered, and even agitated. And these negative feelings can result in a loss of confidence, pessimism, and sometimes a conclusion that life is no longer worth living. So it's really a mood of extremes.
Yeah, and I see, Gary, you were saying that lack of insight, poor judgment, impulsivity, those are definitely part of it. And just going back, like I had a thought about your question with the email. I think the idea is when they're in that manic state, it's like they can be euphoric, they can be happy, but it doesn't seem like an average one. Like something's not going to sit right. And this is a big piece of it. A lot of it is our intuition. And again, because we're not trained in this, It's just the idea that this is maybe a flag that there might be more going on than is under the scope of our training. And so we're giving this education to know that, like, okay, this might be present. And just know that if you continue to, as you're coaching this client, that if there's a feeling there's more going on here, at some point you are going to likely or may want to say, you know, I'm a little concerned. I'm not trained in this. Maybe a referral would be possible. So these are all just, you're taking all this stuff in to add to your toolbox of possible flags. But we wouldn't know for sure. Yes, they're definitely bipolar. That's not within our training.
And I think you'd look at it in terms of a text or email chain, in terms of what else they're describing that's going on in their life. So if they're, I don't know, typical signs would be, you know, racking up huge debt, or impulsive behavior in the middle of the night, or, you know, things that are out of normal activity for that person, staying up all night, which is unusual for them, or, you know, so behaviors that appear to be risky, or and I'm just giving a couple of examples off the top of my head, or dangerous, or, you know, suddenly perhaps having sex with a whole lot of people, or, you know, whatever. And I mean, you know, like, it could be a whole range of different things that are going on. And then a couple of weeks later, or even the next day, all of a sudden they're really depressed and they can't get up. You know, your flags might go off. This seems like there's a health issue happening, because ultimately it's a health issue. So, you know, I think you'd have to look at it in terms of what's going on over a period when it's in text or email. So I don't know if that's answering your question. Okay, great. Thank you. And thank you for asking. Post-traumatic stress disorder and complex post-traumatic stress disorder. So this is a really complex set of illnesses, or two set of illnesses, that may arise in anyone from young children to adults. It occurs after some form of traumatic experience. The traumatic experience may be exposure to actual or threatened death, serious injury, sexual violence, or other forms of trauma. It could be that the person has experienced it directly, witnessed it, or heard about it. That is, that it's happened to a loved one or a friend. Or they may have experienced it vicariously. That is, it's repeated, heard about extreme exposure to adversive details of traumatic events. So it often involves intrusive thoughts and memories of the traumatic events or traumatic stress. It can affect sleeping and dreaming. For example, the person can experience flashbacks to the traumatic events, which causes them to feel like the event is happening again. They may also experience intense, prolonged psychological stress or marked physical reactions to the internal and external cues that symbolize a resemblance to the aspect of the event. It feels like an acute fear and anxiety for the person when they're undergoing a relapse or flashbacks to that traumatic event. And they may also be unable to remember important aspects of that event, which is called disassociation. People with PTSD may experience a range of negative emotions, including persistent and exaggerated negative beliefs or expectations about themselves, about the world, and other people. They may experience irritable behaviour, reckless or self-destructive behaviour. They may be hypervigilant. They may have exaggerated startle responses, and they may have problems with sleep and concentration. Sometimes people with post-traumatic stress disorder have signs of high stress and anxiety related to traumatic events, and they may be severely agitated, irrational, or experience or act on suicidal ideation. Okay. So I wanted to talk about suicidal ideation because I think this leads into it pretty well.
There's a question first. Can PTSD be present due to the death of a family member?
Yes.
Yes.
Yes. Well, that's a traumatic event. So trauma can happen. Our body doesn't recognize, essentially, our body doesn't recognize the value of the trauma. So, it doesn't matter how bad or worse the trauma is, our body reacts to the trauma itself. It's not valuing it as in yours is worse than mine. Trauma is trauma. Okay, I'm sorry to hear that. Maybe we can talk about that after. My condolences. Sorry. Just take care and take care during this next session. This might be really hard on you, and either Michelle or I or both of us can talk to you after.
Yeah, reach out to either of us, both.
Yeah.
Okay.
Absolutely.
We're good.
And thank you for being open as well.
Thanks for sharing that.
So this next section is actually on suicide and suicidal ideation. And, do reach out anybody who finds this difficult. And it is difficult and it's scary. So suicide describes the act of taking one's own life. Suicidal ideation is the term used by mental health professionals to describe people who are experiencing suicidal thoughts, but not taking any action. Anyone who is experiencing suicidal ideation at any level suggests a real risk of suicide. We should always err on the side of caution, as there is a significant possibility that someone who is experiencing suicidal ideation can tip over into suicide as risk factors become worse. Michelle, can you move to the next slide?
Yeah. And I see, assuming you mean they have expressed the feelings. Yeah, it might present as, oh, I want to kill myself, I want to run away, I want to escape, all those kinds of terminology. It would be easier if I wasn't here, those kinds of words. And there also might be situations of suicide where there's absolutely none of that. And I'll just share personally, I was mentioning that my husband died by suicide. We had no indication that was coming. So it could be both ways, but it's just one of those things that if they are saying things that sound like they want to end their life, this is somebody, we're holding something big. This is someone's life at stake. And so we do have to take it seriously and not think, oh, they're just saying that.
That's right. I just want to go to bed. I never want to get up. I want to fall through the hole in the floor. They're all indicators there's something more going on here.
Or even if they're putting their affairs in order and they're talking about that.
Yep.
So these are all, again, it's all flags for you to just say, okay, something's going on here, to keep in mind as you're coaching of how many signs am I getting till I'm really concerned.
That's right. So, and that's what this slide is actually about. You may notice your client, if risk factors for your client. So you may notice your client suddenly puts on weight or loses a whole lot of weight all of a sudden. You may notice they're having a lack of affect, that is a lack of emotion, or they're crying at the drop of a hat. They may be exhausted for no reason. They may lose interest in goal setting or achievement where previously there was no issue with this. They may suddenly talk about, as Michelle said, getting their affairs in order. They may be, an example of this is writing notes to long lost family members, sorting out their will, sorting out their financial affairs, their house, throwing out old photos, whatever. There could be a lot of cues for that. So listening and watching for those types of behavior if you become concerned about one of your clients or someone you know in your life.
Yeah, and there's a question, is our obligation as a coach to notify someone of this? Is this a moment when our commitment to confidentiality is trumped by their well-being?
Yes.
Yeah, I would say absolutely yes. I don't think
100%.
any of us want to think of not having done something and heaven forbid something happening to our client. So my suggestion is to let them know I'm very concerned and I need to call for help.
So there's,
and keep them on the line as well while you're doing that. But it's, safety first. That's really
always
the bottom line.
Yeah. So if you go to the next slide.
And there's a question, who would you call for help? I would call 911.
Yeah, so Michelle, if you go to the next slide, because we go through the process here. Yeah, so excellent, Michelle, thank you. It's good, it's here.
I was like,
and you'll have this
slide.
And there's also an information brochure in the resources, which you can keep as well, which is from the Mental Health Association of Canada, which I don't think is the correct title, but whatever. Anyway, which backs this up, which I found afterwards. Yeah, so if they're at high risk, I would call 911 and never ever leave somebody who is at high risk of suicide. So I think let's go through it in order though, because I don't want to freak anybody out. You cannot put thoughts of suicide into someone's head. If the thought is there, it's there. You didn't put it there, you're not that powerful. And I think that makes us all feel a bit better. If you feel like, or if you're worried that someone is suicidal, the safest course of action is actually to ask outright. It feels scary and it can be really scary to hear the answer. However, potentially their safety is on the line. So this is actually the safest thing you can do for them. So you ask, are you thinking about hurting yourself? Have you thought about ending your life? Or whatever feels appropriate depending on the language they've used with you. Then, to determine the risk, you found out if they have a plan, a means, and a time. If they have these things, then they're at very high risk and you need to get them medical care as soon as possible. And yes, that is absolutely emergency assistance, 911. You do not leave them. If they're lower on the scale, that is, they've thought about it, but there's no plan, there's no means or time, then you can refer them to their doctor and follow up with them to make sure they've made the appointment. Or ideally, you stay with them while they make the appointment with the doctor, and that they state that suicidal ideation or suicide is the issue to be discussed, because then they'll be pushed up in the timeline with their doctor. The doctor may, though, refer them to emergency for an assessment. So just to be aware of that. So here's your little checklist on this slide to make it easy. But I know that in the States and in Australia, if you don't act on the knowledge of suicide, there are legal ramifications. I'm not sure in Canada. So always err on the side of caution. This is outside a coach's realm. It's actually also outside really a therapist's realm. If they're at high risk, they need to be, you need to call 911 if they're at high risk.
As well, we're going to get into the ICF guidelines, but they also clearly state in the materials that we're going to be going through together. I'm just reading off one sheet. They say, if you believe someone may be in imminent danger of self-harm or hurting another person, call a local emergency number. Stay with the person till help arrives. So, the idea of confidentiality, you don't have to tell anybody why you think so. It's enough to just say, I'm concerned about this person's life.
Yeah.
And you're telling your client as well, but that's really all you have to say for action to happen.
Yeah. And when I'm dealing with suicidal client, someone that I'm ringing emergency services for, the number is different in Australia. I always tell my client exactly what I'm doing.
Mm-hmm.
I stay on the line. I tell them what I'm doing. I say I'm calling an ambulance. I'm calling the police. I'm, to come and get you, to keep you safe. This is what we're doing.
Yeah.
And I don't lie to them about what I'm doing. I don't breach, because that's actually where the breach of confidentiality is, if you lie to them.
Yeah. And Katie also brings up a great point, saying that we can work that language into our coaching agreement, saying that the confidentiality is held unless someone's life is in danger. I have that in my coaching agreement, and I also bring it up when I design the alliance. I mean, my clients are very high risk, but it can't hurt to just say, listen, this is what I'm going to do. And I've never had anybody say no. So it's always good to cover it. And Pamela says she does that too.
Yeah.
Great.
Okay.
Any other questions before we move forward? Okay, I think it's looking quiet. Okay,
Yeah, great.
so the ICF has quite a bit of material that they keep very well hidden about mental health, mental illness, referrals, that kind of thing. So I'm going to go through very quickly what the materials are. And as I mentioned at the beginning of the call, this will all be provided to you immediately at the end. It'll be in the files of in the CTI group, so that everyone has easy access to it. So this is the ICF's definition of a mental health issue: an impairment or a recent change in functioning that significantly affects a person's thinking, emotional state, and behavior, disrupts the person's ability to work, carry out daily activities, including basic self-care, maintain functional family and social relationships. And again, these are all flags. We're not in a place to be diagnosing. We're not using any of this to say to the client, I think you have this. It's really, the idea is to say, I think there are some things going on here that are outside of the scope of my training, and refer them on. So again, ICF clarifies how is mental health issue different from a bad day. Someone who's coping successfully with a difficult situation may not feel good, but they understand that they are off, and they can acknowledge it to themselves and their coach. They mobilize themselves towards self-care activities that provide relief for a reset. They're willing to rest, get enough exercise, sleep, and to right themselves. And they're capable of responding to practical and emotional support from family and friends. The idea is that they're able to see what's going on, and they're able to be proactive in moving out of the bad day. It's not a place where they're just stuck in it. Depression, as Natalia was saying, is that heaviness, the lead feeling, where even just brushing their teeth might be something. So and it's prolonged. We can all have bad days or even a bad week. And it also depends is there a reason for it? Did something happen that's causing our mood to be lower than it normally would be? So things to look out for. So I'm not going to read all the details here, how the ICF talks about the symptoms. Again, it'll be in the materials, but just to know that these symptoms may show up in different areas of the person's life. So depending on the topic they're bringing up, it's important to know. It could be about their presentation. It could be issues at work. It could be at home, like I was mentioning, not being able to brush their teeth, so not being able to do the basic necessities of their daily life. Financial difficulties, communications, and their health. Just, overall, it's that lack of control, lack of insight sometimes. And here they get very specific about the signs of potential mental health issues in coaching. So if you're asking them, scale of 1 to 10, how are you doing on any of these levels, and they're consistently low, that's a flag. Something's going on. If they can't stay focused on the agreements, they're doing their homework, the accountability, nothing, it's not happening. It's, again, something to be questioning of what's happening here. Is there something more that's holding you back? If they're not able to think critically, step back and evaluate their assumptions or beliefs, or respond to powerful questions.
There's a question about specific obligations with a client coping appropriately. Do we still refer them?
Could you expand on what you mean by coping appropriately? And I'm going to keep going to there while you, if you don't mind explaining that.
That's from Jason.
Yeah. So, and then going back to the signs, if they're overly focused on what others are doing, so they can't, it's the lack of insight, they're blaming everybody else for what's going on. If they have difficulty scheduling, keeping, or paying for coaching appointments, again, it's a flag. And a common one that I see a lot with my clients want to stay focused on the tips or tactics of just give me the list of what I need to do. And they don't want to dig deep. They don't want to go anywhere near emotion. And which leads to the next point. They are weepy and express either intense or flat emotion. So you might get either one. And again, that alone is not a flag, but it's over time with other flags that you're noticing. Sorry, I just see Jason, you added here. So do we have any specific obligations? So we're going to get to that, but that's where, as you're noticing all of these, you may want to be referring them. So we'll touch on that. And if I don't cover it, please add in the chat that you still have further questions.
I think
Yes.
I think the thing is that in the ICF guidelines, they're kind of taking the extreme view. I don't know of.
Hi guys, it's Jason here.
Hi Jason.
I'll just clarify the question.
Yeah.
You had made reference a few slides back about people who seem to be actively managing their issues, seeking help, getting rest. Now, was that taking them out of mental health issues and you were describing people just having a bad day? Or were those people with mental health concerns, but in the moment seemed to be managing okay? So my question is, those with mental health issues who seem to be managing for the moment, what's our obligation towards them?
If they're managing for the moment, they're managing.
Yeah.
And
Okay.
really, so much of it is a judgment. You're looking. This is not going to be it could be a quick one-time, decision if it's something very extreme. But these are all things that, like, over time, your intuition is saying something's up. And and that there is no reason, like they can't explain why they're always feeling down or why they can't function. It's not like, they just lost their job and they're devastated. Like that it could lead to depression, but that also could explain what a bad day looks like.
I gotcha. So we use some judgment in distinguishing bad day from a pattern.
Yeah,
okay.
And I think
thank you so much.
The other thing that's helpful to know about mental illness is that a lot of them are episodic, and it's a recovery thing that can come and go. And so if someone has a mental illness, it can get better and then it can get worse again, and then it can get better and it can get worse again. And often the family members and carers will help them watch for their for cues of when it's starting, when they're starting to come out of what they call come out of recovery. So when some of these symptomologies start rearing their head, so they might be managing really well for a while, and then they may not.
And again, it's all in the context of coaching, of, you're getting a feeling that there's something going on here that we don't have training on.
Exactly.
It's more in the coaching, you're like, something's, and we're going to actually cover that shortly. And I don't want to rush people, but we only have 20 minutes left, and it's an important stuff to cover. So I want to just move through so that we can open it up to a Q&A at the end. So again, the ICF is quite clear on the difference between psychotherapy and coaching. They don't leave anything to the imagination, but they are, essentially it's about, we can't diagnose or treat. We haven't been trained in any of mental illness to be able to do that. We're their supportive partner. And this is the place where, as their supportive partner, if we're feeling something is up, this is where we get to be their partner and say, I'm feeling like something is up and I'm concerned about you. Let's look at other options. And again, the client capable of generating new approaches and solutions. They're forward moving. They're not stuck in the same place. They're moving toward greater mastery, focusing on action and growth, and they're focusing on the present and preferred future states, that they're not hung up in the past. A lot of times you'll get the clients who are hung up on the old stories that they keep telling over and over, that usually involve blaming somebody else for what's gone wrong in their life. And again, one time it's not a big deal. It's trusting your intuition of this. I don't feel like I'm able to coach this person. We know what coaching looks like. So these are just flags that maybe this is outside of our scope. So this is tiny, and I apologize, but there is a full-sized attachment in the group. I'll just name the 10 indicators that ICF lists to refer a client to a mental health professional. Your client is exhibiting a decline in his or her ability to experience pleasure and or an increase in being sad, hopeless, and helpless. Number 2, your client has intrusive thoughts or is unable to concentrate or focus. Number 3, your client is unable to get sleep or awakens during the night and is unable to get back to sleep or sleeps excessively. And again, they get into details and scenarios. Number 4, your client has a change in appetite, decrease or increase. 5 is your client is feeling guilty because others have suffered or died. 6 is your client has feelings of despair or hopelessness. Your client is being hyper alert and or excessively tired. Your client has increased irritability or outbursts of anger. Your client has impulsive and risk-taking behavior. And then the last one, your client has thoughts of death and or suicide. So again, they're very clear on what is within our scope and not. And so this is great information for us, because we're always wondering, when can I continue coaching? When do I hold off and refer them out? Or do it, simultaneously, and when should I just completely be terminating the relationship? So again, this is all ICF material. So we can continue coaching if the client acknowledges the behaviors and barriers to progress that you have observed. They're willing to seek and or accept a referral. They actively engage with the referral, and they are able to benefit from the coaching process and achieve goals. Postponing coaching. If the client is willing to consider accepting a referral but doesn't take action, and the coaching process remains stalled or deteriorates due to continued presence of the client's problem. Terminating the client's issues fall outside the coaching scope of practice. You feel you do not have the education, resources, or skill to help. You are uncomfortable with the client or wish they were not your client. And the client denies any problem. And again, they blame others for the existence of their problem. They refuse to deal with issues except through the coaching process. And they imply that if you were a better coach, there would not be a problem. So that leads into our saboteurs.
It does. So I think in all of this, and I'm just going to cover this really quickly, it's important to notice our saboteurs, the little negative voices that are happening in our head when someone comes to us, or in a discovery session, or a client comes up with issues that might seem a bit bigger than we're used to, and what our own story is that we're telling ourselves. I'm not good enough, I can't lose this client, issues of scarcity, or am I holding myself or my client naturally creative, resourceful, and whole? What's my opinion of therapy or the mental health services? What are your own stories that you're telling yourselves? What I know I have stories that I tell myself. I have a particular view of having to diagnose, that I have to watch myself on. You know, we all have these voices. So yeah, like we all, have to address these negative saboteurs that we have in our heads. So yeah, I think it's really important to address those, because these are big issues for the clients, and it's really important that we hold ourselves as big and creative and stand strong. So I thought I'd open it up, but we don't have much time. Do we want to hold it off, Michelle, and open it up after? Or
yeah, let's do that.
So we can maybe address that.
One?
Yeah, do you want to go to the next one?
Yeah, and just noticing when your saboteurs are coming up, we're all great coaches.
Exactly. Go to the.
If you're starting to feel like, if your saboteurs are starting to question, it's a sign that maybe this is outside of the scope. And again, because it's somebody's life that's on the line, we always want to err on the side of caution. So just noticing that, and just saying, okay, maybe there is, I do need to consult, or they need to be referred out.
Exactly. That's right.
Move to the next one.
Yeah, move to the next one, because we are all good coaches. And noticing that by using your skill and your tools and exactly, I third the motion, I fourth it, and your intuition and setting your boundaries, you are actually making a really positive difference in your client's life, and in fact in your own life, by standing tall and standing strong.
And remember,
the best thing you can do.
You may be the only person in their life who has the courage to say to them, I think something's going on, and I would love for you to consult with somebody.
Yeah.
So, it's a very, this is a very important role that we have. They're trusting us with so much of their life, and we are making a difference. And so again, going back to the saboteurs, it's not a failure on your part as a coach if they need to be referred out. This is actually such a great service that we're providing our clients by noticing these flags and saying, this is something outside of the scope of what regular coaching would be.
Exactly. Yeah.
Okay. So now, grounding techniques. Just to offer a couple of these, there's a few different things we can do. So again, as I mentioned, if your client is, having, say, a panic attack in the middle of a session, if there's something very emotional going on, we don't want to just end the call and like, all right, talk to you next week. The responsible thing to do for both of us would be to get to ground yourself and the client before you end the call. So there's different ways that you can do it. This little meme describes there's by doing it through the body, by noticing the five senses, self-soothing, although you can't go take a shower while you're on the call, observing the breath, and distraction by just having them point out things that they're seeing. So I was just going to say, if everybody just I was going to pick one of the breathing exercise, which is really my favorite. And it's practicing inhaling for a count of 4, holding for a count of 7, and exhaling for a count of 8. So if you guys are open to it, we'll just do it once or twice, and you'll see the impact that it has immediately. So we can all just take a deep breath in. 1, 2, 3, 4. And then hold it for 6, 5, 4, 3, 2, 1, and then exhale for 1, 2, 3, 4, 5, 6, 7, 8. And if you want to do it one more time on your own. So I'm curious if you want to put in the boxes, in the chat box, how you guys are feeling from that. And thank you, Jason, for your comment there. Marla says calming. Thank you, Marla. Okay, everyone else is too calm to comment. Very grounding. Yes, grounded, centering. Thank you. Yeah, so it's a great practice. I try to actually do it almost every session with clients. Sometimes they need it in the beginning too, just to get present. Feet on the floor. Yep. If they need to do it 3 times, I usually do it 3 times, but I'm just trying to be mindful of the time. Yeah, 3rd time's the charm. Okay, so, and Deanna often depends on it. Yeah, I hear you. Okay, so then just that quick one-sheeter that is going to be in the files, the when and how to refer a client. So that's a great tool to have handy. And then about us. So everybody can unmute if they'd like, if they have a question, and we can just open it up to any questions, comments, whatever you've got.
Well, I'll jump in.
Okay.
And say something. It's Deanna.
Yes.
You know,
Okay.
and Jason said it also, and I wanted to make the same point, that it's very empowering to know that we may be the very first person to alert somebody of a condition that could be happening, because it's hard to see these things in ourselves when they're happening.
Yeah.
And it just reminds me of being a doctor, like a family physician. You know, it is a doctor, but really a physician, a general physician's job is to direct you to the right specialist.
Yeah.
Oftentimes,
Yes.
right? There are the things that he can do or she can do, and then you send them off, and it's not any less doctoring.
Right. Thank you. That's a great point.
Them to their right specialist.
Yeah.
Absolutely.
You're exactly right.
Yeah.
I'm going to add to that, Diana. It's empowering and super scary, because I'm not looking forward to the day that lands in my lap. I inferred a few things in my text there, but that was related to an ex-landlady who is like gone really nutty. So, but you know, see, it just goes to show that it's not just from a coaching standpoint, it's from life as well. It's like to know, not to deal with it, because I'm not going to deal with that lady. In fact, we blocked her and we're seeing a lawyer. But just to know that, okay, so it could be this, and I'm not a therapy person. So, you know, it's kind of very interesting. I loved it.
Thank you.
Thank you.
I'm just going to share, it's Kristen. Gary, just to let you know, I have been in that position with several clients, and I have been with my father this summer. And if you hold the person with love, the courage comes from there in that moment. And it is really empowering, and they are so grateful that they're asked. So.
Thank you.
I agree.
Yeah. And Elizabeth was asking about the one-pager. So at 1:00, there's going to be a whole bunch of files added in the Toronto CTI group. If you just go to files, you'll see all of them. You may even see all of my posts. There's going to be a lot of them. So I apologize for all the notifications if you get, but I couldn't put all the files in one. So you'll be hearing a lot from me. There was something else I was going to mention. Oh yeah, if you guys have an interest in other topics around mental health, please let us know. Private message, add it in the event as a comment. We would love to offer more to the community. You know, seeing that there's such a great response. I mean, we had, I think, 28 people or 29 people on the call today. So please do give us your feedback on what you're looking for more of.
Yeah.
And my internet is unstable. I apologize. So, because we would love to know, and we would love to be able to offer it to you.
So this is Donna Lee. Hi, Michelle. Hi, Natanya. Great presentation. I would just like to let people know. So I'm an ADHD coach as well as a CPCC, and I did special training with that because ADHD tends to run in families. And depression, ADHD is more associated with earlier depression. People with ADHD have 4 times the normal of depression, and they have more frequent hospitalizations due to that. They also have more recurrent episodes, and they have a higher suicide risk. And I've got other statistics on suicide, just in that people with this is a Swedish study, not too old, it's fairly recent, that non-ADHDers will have about 1.3% attempts. And compared to that, people with ADHD have a 9.4% of attempts, which is much higher. And 22% of ADHD combined. So ADHD is 3 different ways of being diagnosed. One is ADHD combined, the other is inattentive, and the other is with ADHD, plus then there's a non-ADHD. But they're also very, very high. And girls who report self-injury, 51% of ADHD combined will report that. And it just, women are 4 times, I'll give you the last couple here. Women are 4 times more likely to attempt than males. Males are 10 times more likely to succeed. So if you do have someone like a person with bipolar has a lot of symptoms as ADHD. And so we need to be very cognizant of our clients. And if they do have ADHD, you might know, they might tell you. Often they don't tell you. More likely nowadays, people are coming out of that closet because they know the stigma that they're facing if they do. And some people are more accepting. So I just wanted to throw that out there. It's kind of something that never gets told.
Thank you for sharing that.
Thank you. Wow.
You're welcome.
Just also in the last couple of minutes, I just wanted to mention that I will be sharing a list of mental health resources in Canada with websites, actually not websites, phone numbers, so that you have easy access to them and the names, and you can go do more research if it interests you. Any other questions before we wrap up? Deanna, you're on mute.
Hi. Was that, who was just speaking about ADHD?
That was Donna Lee.
Donna Lee. Donna Lee, will you share that with us? You said it's a study that you were looking at, or an article.
It's research. So there's I can give you a link.
Maybe if you could share that in the group. I'll send it to Michelle, and she can do that.
Perfect. I have a link to a webinar and the slides from someone at Harvard University who is a psychologist, and he's doing a lot of research. His name is Roberto Olivardia.
Wonderful.
He's amazing. So I'll send that to Michelle.
I'll post that. Thank you.
Thank you.
Any other questions before we wrap up?
I'm serious about my comment. You guys should make this an article in Choice Magazine. I personally know the publisher, and I'm sure that he'd want to talk to you.
Okay. Thank you.
Thank you.
Yeah.
Wow.
We'll be in touch then.
We will. Yeah.
You're just going bigger.
Yes.
No, like seriously, this is something that hasn't been written about in Choice Magazine in a long time, since Patrick Williams did the column on coaching versus therapy. And I'm so impressed with your work that I've thrown in a theme possibility to discuss with my managing editor.
Thank you.
Thank you. Wow.
So we'll talk.
All right, let's talk.
We'll talk.
Over coffee.
Over coffee. Yeah.
All right.
All right. Thank you,
Gary.
That's amazing.
All right, guys, it is 1
Thanks.
o'clock on the dot. Wow, look at us. We're so good. This is just the beginning. Yes, I hope so. I hope so. And again, everyone's free to reach out to me privately or not if they have any other questions that I can help out, support. I'm happy to do it.
Yep. And
all right, everyone. Thank you for your time and
yes.
enjoy the rest of the day.
Yes. Thank you, everybody. Thank you for coming. Bye.
Bye.
Bye. Thanks, everyone.